Welcome to the beautiful new Welcome Center at the University of Rhode Island. This is one of the first events to be held in this facility, actually. I'm Bill Renehan. I'm the Associate Director of the George and N. Ryan Institute for Neuroscience at URI. And it is my pleasure this evening to welcome a collaborator, a friend of ours, Dr. Brian Ott from Rhode Island Hospital, who will partner with me in a presentation this evening about Alzheimer's disease, some of the recent advances that have been made, and some of the things that you may be interested in learning about that may reduce your risk of Alzheimer's disease. So without any further delay, allow me to introduce Brian Ott, who will begin, and halfway through I'll take over.
Okay, good evening to everyone. Can you hear me okay? So welcome to our program, and I'd like to express a special note of thanks to University of Rhode Island and to the Ryan Center for hosting today's program. We have a lot of new and interesting information to convey to you, and we hope it will engender a lot of questions and comments. Feel free to raise your hand as I go along, or at the end of our talks, there'll be a lot of time left for some Q&A. As I'm sure you know, Alzheimer's disease is a common problem. It touches all of us in one way or another, and it's on the rise. And the reason it's on the rise is the baby boom generation is coming of age, and so we will see increases in the prevalence of Alzheimer's disease by as much as 40 to 70% in some states. In Rhode Island, by 2025, our prevalence should go up by at least 25%. Currently, there are over 25,000 people in the state of Rhode Island who have the disease. And because of the baby boom generation coming down the line, we're looking forward to what people refer to as a tidal wave of new cases of Alzheimer's disease that's going to overwhelm not only our medical systems, but our social and economic supports for taking care of people with dementia. And so people are starting to get really concerned and almost panicked about what are we going to do, because we don't have a cure or an effective treatment for this disease. What's the way out? The only way is through developing better treatments and ideally developing prevention, if we could do that. And we need to do it now. The federal government recognizes that, and they've been increasing the funding for Alzheimer's research year by year over the past several years. So we have some reason for hope that research will be stimulated to the point where we can come up with effective therapies. It's been estimated that if we could just reduce the onset of Alzheimer's disease, delayed for at least 5 years, we could reduce the prevalence of the disease by 50%. And we think this is an attainable goal within our lifetimes. To recognize the need to have a plan to deal with Alzheimer's disease, Congress passed what's called the National Plan to Address Alzheimer's Disease, or NAPA, in 2011. This plan calls for every state in the United States to have their own specific plan on how to deal with the oncoming tidal wave of Alzheimer's disease. And in Rhode Island, we have one of the best plans, actually. It's a model plan, and that's been in effect for 5 years, and it's currently undergoing revision under the direction of the Lieutenant Governor's office. The first goal of the national plan was to prevent and effectively treat Alzheimer's disease by the year 2025. And so our objectives for tonight's talk is, first of all, I'll give you a progress report on how are we doing at attaining that goal. What are our current treatments, and what are the future treatments that we're developing for Alzheimer's disease? And then the second half of the talk, Bill's going to come on and talk to us about prevention of Alzheimer's disease, which is the new paradigm, the new approach that we're taking. Looking back, Alzheimer's disease was first described in 1906 by Alois Alzheimer. Alzheimer was a German psychiatrist and pathologist at the turn of the century who was interested in examining the brains of people who had mental problems to understand why did they have their problems. And he met this woman, August Dieter, who was in her early 50s when she was admitted to an asylum in Germany because of delusions of jealousy toward her husband and severe memory loss. He followed her carefully, made detailed clinical notes over 4.5 years, and at the time she died, he examined her brain post-mortem. He had a colleague in the German photographic industry who was using a silver stain to develop photographs on glass plates. And he applied that silver stain to the brain slices of August Dieter, and that enabled him to define the plaques and tangles of the disease that now bears his name. And so we call it Alzheimer's disease. So after that, there was a long period of time where there weren't any real advances being made in understanding, and certainly nothing in the way of treatment, until the 1970s, when a lot of work started to be done trying to understand amyloid and the plaques and the tangles of Alzheimer's disease. And around that time, it was realized that the major chemical deficit in the brain was a chemical called acetylcholine, which you need for normal memory function. So with that recognition, people got the idea, oh, well, let's treat Alzheimer's disease like we treat Parkinson's by augmenting that deficient neurotransmitter. And so a number of clinical trials were done in the 1980s and 90s of drugs to augment the brain to have higher levels of acetylcholine. And the first successful trial examining what we call the cholinergic hypothesis was a drug called Tacrin, which was reported in 1992 to be effective in improving memory loss symptoms in people with Alzheimer's disease. And so Tacrin the next year was approved as the first treatment for Alzheimer's. And this was about the time that I started doing research in Alzheimer's disease. So I go back quite a ways myself in the field. But those were exciting times because now Alzheimer's disease was a treatable illness. And so all of a sudden now people started coming in wanting to be diagnosed because there was something, not a great treatment, but there was some treatment at that time. Wasn't a great treatment, it was pretty toxic, and you had to take it 4 times a day, which is hard if you have a memory disorder. But so we don't really use that drug anymore, but there are 3 other drugs that were successful in trials, and these 3 drugs listed on the slide are the mainstays of symptomatic treatment for memory loss and Alzheimer's. Later on, we had another drug approved for treating Alzheimer's symptoms called memantine that worked on a different chemical transmitter called glutamine. As it turns out, the combination of memantine with one of those other drugs is better than just the cholinesterase inhibitor alone, so that tends to be what we strive for in our day-to-day management of Alzheimer's symptoms. A lot of times you hear people say, well, these drugs are okay, but they only work for 6 months and then they don't work anymore. That's really partially true, not completely true, but what happens is none of these drugs work on the disease itself, so they don't stop the progression of losing nerve cells or neurodegeneration. So over time you do get worse, and then people say, well, that means it's not working, but if you stop the drug, you're worse off than you ever were before. So they're still providing symptomatic benefit. As shown in this slide from the memory clinic at Massachusetts General Hospital, they looked at their clinic population and compared people who didn't get any of these drugs. They're on the gray line, if you look at the top slide, showing the most decline, and then people just getting a cholinesterase inhibitor are in the green line, and they're kind of intermediate, and the people who got a combination of the cholinesterase inhibitor and the memantine are doing better than the other 2 groups, even at the end of 4 years, 4 years. So these drugs do have beneficial symptomatic effects that last for years, but it's not the final answer because everybody gets worse despite the treatment. So we have to do better than that. And so in the 1990s and the current turn of the century, we moved away from these symptomatic treatments and neurotransmitter augmentation to look at other ways to treat Alzheimer's disease that might change the course. And so we looked at large epidemiologic studies to see, well, what factors, what kind of drugs already being used were associated with less development of dementia. And that led to trials of things like anti-inflammatory medicines, estrogen for women, statins, omega-3 fatty acids, but none of those trials succeeded. So that approach didn't work. And so now in current times, we've turned away from looking at epidemiology for the clues, and now we're going back to what Alzheimer did and looked at the brain. And we're understanding now what are these plaques and what are these tangles, and using those as our targets, because that's how you diagnose the disease. You would think if you can eliminate those things from developing or take them out of the brain, maybe you could effectively stop the disease or prevent it. And so that's where we're at right now. There are a number of pivotal phase 3 major trials going on, particularly looking at ways of reducing amyloid in the brain. And we're going to have results from those studies published or publicized in the next few years. So we're getting there. And along with understanding more about amyloid and what goes on in the brain with Alzheimer's disease, we have a totally new way of looking at Alzheimer's. It's not an old person disease anymore. It's actually a lifelong disease. It's a lot like atherosclerosis. Normally with aging, you'll have some declines in your memory, but it's not significant. With Alzheimer's, on average, you diagnose it in the mid-70s, and then you go through this rapidly progressive course of memory loss and dependency we call dementia that lasts about 5 to 10 years. As it turns out, there's an intermediate phase we call mild cognitive impairment, intermediate between normal and dementia, when people have measurable memory loss, but they're still functioning well. And this is actually when we're seeing people come into the clinic now. They're not waiting until they have dementia, until they can't function. They're coming in when they're having memory difficulties. And with the help of modern imaging techniques and biomarkers, we can actually make a diagnosis of Alzheimer's in many people, even at this stage of the illness. As it turns out, the actual pathologic changes of the Alzheimer's disease, the plaques and tangles, start 10 to 20 years before you have any symptoms. And so that's what I said. It's like atherosclerosis, which is also a plaque-forming disease. With atherosclerosis, the plaques start building up in your vessels and you have no symptoms for years and years, but you have risk factors for that developing, like diabetes and hypertension and smoking and so forth. And those risk factors lead to the pathology that goes on and on. And then you get to a certain threshold where if you have so much plaque, you block your vessel, you get a heart attack or a stroke, and then it's too late. And so we think that's what's happening with Alzheimer's disease and the plaque formation in the brain of Alzheimer's. If you wait till you have dementia, it's too late. And we need to look at either the MCI stage or maybe in the asymptomatic stage to develop an effective treatment. So we're moving now towards the age of early diagnosis and early intervention for Alzheimer's. It's still true. The only way you can diagnose the disease for sure is to look at the brain post-mortem, as Alzheimer did, and show the microscopic changes of the amyloid plaques. These are deposits outside the brain cells, and tangles, which are protein collections of a protein called tau that build up in the nerve cells themselves. As it turns out, we now have tools at our disposal that enable us to see plaques and tangles in living people. So we can make these diagnoses with confidence in living people. We don't wait till post-mortem. For instance, we have a technique called amyloid PET scan, which actually is approved for clinical use by the FDA. Unfortunately, insurance won't pay for the scans. We've been using it for years in our research. And with amyloid PET imaging, you can see in this slide, on the bottom is a person who died and shortly before death had an amyloid PET scan. So you can make a close correlation between what's on the scan and what's in their brain. And you see high levels of plaque on the right and really high levels of intensity on the amyloid PET scan showing all of those plaques. Those are in the orange and red collection areas, as opposed to the one on the top where there's no amyloid and there's no orange and red areas. And the one in the middle is an intermediate case. And furthermore, now we have tau PET imaging, which enables us to show the tangles. So with PET scan, we can show both plaques and tangles in people who are living. So this enables us as researchers to know who for sure has Alzheimer's because they have positive scans on these things, even if they don't have symptoms. And also, it enables us to give drugs to reduce plaques and reduce tangles, and we can use these scans to show if the treatment's working objectively. So this has been a major advance that's been made in the past 10 years. And to give you an example of some success we've achieved, there was a preliminary study, what they call a phase 1b study of an anti-amyloid antibody called aducanumab that was given to people with early Alzheimer's disease. And these people all had positive amyloid PET scans, so we knew they had the stuff in there you wanted to get rid of, and the amyloid helps the body clear the antibody helps the body clear the amyloid out of the brain. And these are the results of that study. After a year, on the top you see people got a placebo, and all that red stuff is still there, it hasn't changed. But with increasing doses of the antibody given monthly over a year, you see more and more amyloids cleared out of the brain, and the one on the highest dose on the bottom looks like a normal PET scan. So these treatments do work in terms of reducing plaques and tangles, which is great. Your brain looks better, but does that make a difference? At least in this trial it did. This is a chart showing the clinical dementia rate, which is a scale that shows memory, orientation, judgment, and daily living activity levels. And what we see is on a placebo, there is significant decline, but on increasing doses of the antibody, there was less and less decline over the course of a year. So these are very promising results. We were very excited about that. It looks like something is working. But in order to get a treatment like this approved, you have to go on to what we call phase 3 trials, where you then give the treatment to thousands of people and you do it twice so you can replicate your results to show effectiveness and safety. And that's where we're at with aducanumab. The aducanumab trials have completed their enrollments, and now for a year and a half they need to be completed, and then we'll get the results. And if they're positive, it will most likely end up being a new and effective treatment for Alzheimer's. So stay tuned for that. So where we're at is we don't have a shortage of ideas. We don't have a shortage of techniques to recognize the disease. There are over 100 different clinical trials now looking for participants, for volunteers. What's holding us back now are volunteers. We need people to step up and volunteer for these studies, because if you can't increase the rate of enrollments, it takes a long time to get the people enrolled in these studies, and then it takes a long time to do them. It takes a year and a half, some studies 4 years to complete them. So the longer it takes to enroll, the longer it'll take before we get to that goal of having the effective treatment by 2025. At our particular center, we're looking at a number of different approaches to find that effective treatment. We're looking at amyloid inhibition, such as the aducanumab trial, and another one against amyloid called Trailblazer. We finished participation in a multi-center trial of intranasal insulin. Alzheimer's disease is like type 3 diabetes of the brain. The brain cells become resistant to insulin, and that contributes to amyloid deposition. So the results of the intranasal insulin study are going to be announced in a meeting in the next month or so. So stay tuned for that. Here at University of Rhode Island, we are partnering with Butler and Mood and Memory Disorders under the leadership of Dr. Paula Grammis to inhibit inflammation and blood vessel changes in the brain that can lead to Alzheimer's disease. Very innovative approach, and we're looking forward to starting that study in the near future. So stay tuned for that over the coming months. And the last approach we're looking at is inhibiting not plaques in the brain, but inhibiting tau, the protein that's in the tangles of Alzheimer's disease. And I'll show you a little video about why we think that might be an effective approach. That's the conclusion of my presentation. I just want to close by encouraging you, don't wait. If you have Alzheimer's, or if you know somebody who does, get them in, sign up for the clinical trials. We need your help. And if you want information about clinical trials, be happy to talk to you at the back desk. There's a flyer about the anti-tau trial, for instance, and we'd be happy to talk to you more about that. Thank you.
Thank you, Brian. So, I'd like to begin by asking the people in the room a couple of questions. And the first question I'd like you to answer is a true or false. And the question is, do you think that dementia, that is a decline in memory or other thinking skills, severe enough to reduce your ability to perform everyday activities, is a normal and/or inevitable part of aging? How many people think that's true? Okay, some people do. Some people may be unsure. Some people may think no. As it turns out, the answer is no, it's false. But, hit too many buttons. But studies have shown that between 1/2 and 3/4 of the people that are asked this question think that dementia is a normal part of aging. I have another question for you. True or false? There is nothing we can do to reduce our risk of developing dementia. How many people think that's true? Oh, you're a wise audience. It is indeed false. Most people do believe that there is nothing that they can do to reduce their risk of dementia. But there is evidence that there are things that we can do to reduce our risk of dementia. And this is something that's very important for those of you like myself who may have close family members who've been diagnosed with or have passed away due to Alzheimer's disease. And when you are the child of someone who's died from this terrible disease, and you know that just the fact that your parent has died of Alzheimer's disease, you become worried and you think, what can I do? You know, short of reaching a stage where I may be appropriate for a trial, what can I do today? So let's pause for a moment to discuss the risk factors for developing dementia, particularly Alzheimer's disease. Now, most people that develop Alzheimer's disease are greater than 65 years of age, and they're considered to have sporadic or late onset Alzheimer's disease. The risk factors for late onset Alzheimer's disease are older age. Okay? You're old for 65, so that that's a risk factor. Having a family history, and carrying the ApoE4 allele of the E4 type of the ApoE gene. And I can explain a bit more what that means. You may have questions about it. We can come back to that. These are known as non-modifiable risk factors. There's nothing we can do about aging. We're going to age. We can't change the fact that we have a close family relative that has Alzheimer's disease or had Alzheimer's disease, and we can't change our genotype. So these are the non-modifiable risk factors for late onset or sporadic Alzheimer's disease. And it's important to note that each of these factors increases your risk, but none of them guarantees that you're going to get the disease. So are there modifiable risk factors that we can address, that we can address to reduce our risk of getting Alzheimer's disease? Yes, there are. In fact, a recent report published in the prestigious journal The Lancet by the Lancet Commission estimated that modifiable risk factors account for at least 35% of the risk of developing dementia. And one of the best papers that illustrated the relative value or the evidence in support of this came from a paper published a few years ago, sponsored by the Alzheimer's Association. And they looked at all the evidence, all the studies that had been performed to date, to look at what is the strength of any given intervention, the evidence that suggests any given intervention may have value in reducing or increasing your risk. And when they looked at tens of thousands of papers that have been published, they found that there was pretty good evidence. I have my analog pointer here. Pretty good evidence that traumatic brain injury does increase your risk of developing dementia. And you've probably heard that in the media and through many different mechanisms. There was moderate evidence that midlife obesity, hypertension, current smoking, or diabetes might increase your risk. There was unclear evidence, but some indication that depression, a history of depression, sleep disturbances, or hyperlipidemia, a condition that you might take statins for, might increase your risk. As far as things that might decrease risk, the strongest evidence at the time that this analysis was done was that the years of formal education decreased your risk. This relates to a concept known as cognitive reserve. It's a poorly understood concept. There's evidence that the years of formal education that one has experienced, as well as continuing to stimulate your brain through reading, challenging activities throughout life, somehow decreases your risk of developing dementia, or at least delays the onset of cognitive decline. And it's thought that there's something that happens in our brains that makes us more resilient. It may be that there are more neurons born. It may be that there are more connections between neurons. It may be that neurons have strengthened pathways that connect each other. The mechanism isn't completely understood, but there is very good evidence that education and continuing to challenge yourself, challenge your brain, does decrease your risk. At the time this study was done, there was moderate evidence that physical activity might decrease your risk of dementia, lower evidence that a Mediterranean-style diet or cognitive training might decrease your risk, and the evidence was unclear that moderate alcohol consumption and social engagement might decrease your risk. More recently, in the past couple of years, not unexpectedly, there have been many more studies published since this earlier paper was published that have provided us with additional and stronger evidence for some types of lifestyle intervention. One that I chose to present tonight related to obesity. And in this study that was conducted in Europe, the United States and Asia, they demonstrated that people who had a higher body mass index in midlife had a higher risk of dementia in later life. And this is a theme that has become apparent in many of these studies. It's not just what happens and what you're doing later in life. You are setting the stage in midlife for what's going to happen later in life. Just as Dr. Ott said in his presentation, as they're now looking earlier and earlier in the progression of the disease for interventions, for pharmacologic interventions, we're learning that you have to start paying attention to your risk earlier and earlier in life because it takes decades for this disease to occur. Another study that I wanted to show is that it's been shown that better midlife cardiovascular fitness is associated with better cognitive function at that time, and also it produces a reduced risk of cognitive decline 20 years later. In fact, there's a study that was done in Scandinavia that I'm not going to present tonight, but they found that women who engaged in very vigorous activity in midlife may have had as much as an 80% reduction in their risk of developing dementia in later life. Similarly, there's a study that was done in Europe that showed that many chronic diseases, including Alzheimer's disease, the risk was significantly lower for vigorous physical activity at least once per week. Now, this study didn't find this very high reduction that I mentioned just a moment ago. It's probably because there is a relationship between how vigorous the activity is and how often you engage in it. So this is something that's being studied in many centers worldwide right now. Exactly how much activity is needed and how vigorous does it have to be? One of the things that's neat about the University of Rhode Island is we have kinesiologists who are expert in studying this. One of the problems with the literature is that people that aren't trained in kinesiology will often say, well, it was vigorous, or it was moderately vigorous, and it's their own definition of what vigorous or moderately vigorous might be. Kinesiologists can attach a number to that, and they can tell you that a certain level is or is not. And this is going to turn out to be important because those of us that want to know exactly how many times we have to jump on that exercise machine to have an impact are curious. We want to know, well, what sort of level do I have to achieve? How often? Is a walk around the block good enough? There's actually evidence that it may be. So the story has yet to be answered completely. Another study has shown that the risk of dementia associated with diabetes, especially diabetes that had been present for many years, was almost as great as the risk of carrying that ApoE4 allele. So some of these things that in that study that I presented at the very beginning that were indicated to be evidence was moderate, evidence unsure, we're now finding that the evidence is actually quite strong for these, the importance of things like diabetes, physical activity, mental stimulation. One last thing that I'm going to talk about is somewhat controversial. There's been some discussion in the media as to do brain games help? Is there any value to these technologies? As it turns out, there's evidence that a certain type of memory training does have value. And it's not really memory training, it's actually speed of processing training. It's a special type of computerized stimulation that's done to help increase the speed at which one can solve problems and go from one task to the next. For some reason that's not completely well understood, this is especially valuable, and it has value where there's actually relatively limited evidence for value of doing things like just learning to memorize a list better and practicing that. It turns out people get better at memorizing many things, but it doesn't seem to impact their risk one way or the other for cognitive decline. So in another paper, actually the one that came up with this result, about 35% of dementia being related to modifiable risk factors, they grouped the various risk factors, and one thing that you can see is that many of the factors that seem to be important and valuable in reducing one's risk are also cardiovascular risk factors, such that the saying, what's good for your heart is good for your brain, is in fact true, with virtually no exception. Things that have shown to be good for your cardiovascular fitness are also good for your cognitive fitness. Probably not surprising given the incredible blood supply that the brain has and the amount of energy that the brain is deriving from this rich blood supply. But as you see up in this upper right corner, and as I mentioned a minute ago, it's also important to pay attention to our cognitive reserve. So it's very important as a society to make sure that young people stay in school. This is a value to that we perhaps hadn't appreciated at any other time. It's important to pay attention to preserving your hearing, another risk factor that's shown to be important. If you have a hearing difficulty, there's good evidence that having it addressed and getting assistance is very valuable in decreasing your risk. Some types of cognitive training, such as speed of processing training, are probably going to be helpful. One of the things that Dr. Ott had mentioned is that it was at one time thought that we could try reducing inflammation using non-steroidal and other types of anti-inflammatories, and it may be beneficial in stopping the progression of the disease. It wasn't successful when used after one had been diagnosed. So there's pretty clear evidence that you can't use this approach once one is developing the disease to the point that you have symptoms. But there is some evidence out there that's not yet clear that perhaps approaches that reduce inflammation when begun earlier in life may have a benefit in reducing cognitive decline and dementia later in life. So this is something that is actually being studied at the Rhine Institute pretty intensely. One of the things that we're most interested in is the contribution of inflammation to dementia. So how can you learn more about Alzheimer's disease prevention and Alzheimer's disease prevention trials? One place that I'd encourage you to visit would be our website for the Ryan Institute. You can also visit the website for the Rhode Island chapter of the Alzheimer's Association, a tremendous resource. And there are prevention registries that one can access. There are national prevention registries and local prevention registries. One of the registries that we support is the local registry that was actually begun by Dr. Ott's group at Rhode Island Hospital. It's the Rhode Island Alzheimer's Disease Prevention Registry. And it has the advantage of allowing you to speak to people that are knowledgeable and also local. And you can learn about things that are happening locally, trials that are happening, get information. They have a regular newsletter that is sent out to people that sign up. You can sign up right in the back of the room. It is a way for you to learn about prevention, to get connected to prevention trials as they become available, and a way to gain some information about these things that we're learning, continuing to learn about, that you can do to decrease your risk. The University of Rhode Island partnered with the Rhode Island Alzheimer's Disease Prevention Registry last year. So we actually have people at URI who can meet with you. You don't have to go all the way to Providence to participate in the AD Prevention Registry. You can actually go as close as our building nearby, and Diane back there in the back of the room would be happy to meet with you. You can reach her via phone or email, or go to our website and learn more information. And as I indicate on the slide, you could go all the way to the back of the room and learn some more as well. And so now I'd like to invite Dr. Ott up and encourage you to ask us questions. When I first attended one of Brian's presentations, I found that the part that I enjoyed the most and learned the most about was after the presentations, and people got a chance, some of them who were Brian's patients or had family members who were his patients, had a chance to ask things that they'd really never had a chance to ask before. So please.
Ask away.
Ask away. Yes.
Yeah, years ago that was a concern that was actually studied with a clinical trial of a drug called nimodipine, which blocks calcium leakage. It didn't work, didn't have any effect. So I don't think it's a major factor.
Yes.
So I'm an occupational therapist. I work with patients who have Alzheimer's and other forms of dementia on a day-to-day basis. I'm just curious, there's obviously some really wonderful pharmaceutical interventions for Alzheimer's and dementia, but have there been any trials or studies with pharmaceutical and non-pharmaceutical interventions to help either slow dementia or improve independence or anything like that?
I can start and you can finish. So my perception is no. And part of the answer to that is because when pharmaceutical companies are trying to bring a drug to market and they're doing the trials that are necessary to accomplish that, they have to minimize the variability, and including lifestyle-related variabilities that might impact their results. And as more evidence accumulates that lifestyle interventions may be important, it becomes important to try to minimize that impact. Now, that said, there have been, there was just finished a large multinational trial called the FINGER trial that looked at multimodal lifestyle interventions in preventing cognitive decline and actually also in treating early dementia. And there was very encouraging evidence that that approach can work. And there's going to be a worldwide, including the United States, effort to expand that study. And I personally, and I'll let Brian take it from here, but I personally think that ultimately the gold standard treatment for Alzheimer's disease will involve both lifestyle-related interventions as well as pharmacological interventions.
Right, so that's a great answer. I agree. But yeah, as scientists, we like to isolate that one thing that works. And the FINGER study that Bill mentioned was like an innovation in research where they said, we're going to look at a bunch of things all at once, you know, brain training and exercise and diet, do all of those things. Why not? And, you know, it makes sense. Why not combine exercise and diet and things like that with your drug therapy to get optimal effect? And so there is some movement now thinking about designing those types of clinical trials that are what they call multimodalities. So it's really an excellent question. I think that's what we should do. I mean, there are actually multiple factors that can go into getting Alzheimer's and have your brain degenerate. So we should probably do, it may be ultimately the treatment for Alzheimer's is going to be multiple treatments and approaches at once.
Yes? So the question was, if you're already taking something like Aricept, can you still participate in a clinical trial? And
yeah, that's a good question. All the trials are designed so that you take your basic general practice therapies. So the clinical trial is in addition to your Aricept or your memantine or your combination, but you want to be treated with those and on stable medication, because then when you're in a trial, they don't want to change your medication. So just about everybody in trials is on those medicines. If they have Alzheimer's, and many people with just mild cognitive impairment are already on those medicines, but they just have to keep their dose and their prescription stable and don't change it.
you had a question up front, yeah.
Yes, back to one question ago, multiple modalities approach. When is that coming?
So the trial that I was referring to is sponsored by the NIH, and there are a number of sites throughout the United States. Unfortunately, we tried to get one in Rhode Island, and we weren't very successful in that. But it will begin recruiting, if it hasn't already, very, very soon. Do you know if they've started recruiting for that? It was announced last year. Recruitment was due to start now. I'm not sure whether or not recruitment has actually started, but it'll be very soon. I believe the closest center is going to be Boston. Yes? Yes, I can try. I'm not an expert in this by any means. And so as I understood the paper and read a little bit about this, they used a computerized paradigm. They had people sitting in front of a computer monitor, and they gave them tasks that challenged them to accomplish multiple tasks faster and faster. And so it wasn't where they were given a list and asked to memorize the list and maybe asked later if they could, how many they could do, keep practicing and trying to get better at that. It was directed very much at just doing mental tasks faster and faster. So an example might be giving someone a string of 3 or 4 numbers and asking them to add them, and just challenging them to do it faster and faster and faster. And that specific type of intervention seemed to have value later when they measured cognitive decline and cognitive function, whereas just memorizing and doing some of the other tasks that you might have heard about, they didn't seem to have that value. So it's a relatively fertile area for research right now, because as you can expect, companies would love to know what's the key, what is the thing that we want to market. And so there's a lot of attention being devoted to exactly what one has to do to achieve that result. Yes?
With regard to the handicap trial, was there, as there was a reduction in plaques, was there an observed increase in cognitive capability or correlate?
Yeah, so people did not improve in their cognitive ability, but they declined less over the course of a year. So at the highest dose, there was minimal decline at the highest dose level. So it's really more of a preventive or stabilizing approach rather than an augmenting approach to improve your function.
Yes. Again,
that's a good question too. What's the flip side of the coin? And yeah, when you get amyloid, it builds up in the plaques outside the brain cells, but outside the brain cells also your blood vessels. So you can have, some people have the amyloid plaques building up on their vessels. So these antibodies are not discriminating where the amyloid gets taken out. And so if you start stripping it off your blood vessels, those vessels can become leaky. So what we saw as side effects were brain swelling, or what we call edema, which can cause neurologic symptoms like headache, dizziness, gait problems, and also small hemorrhages. And those are kind of scary things, but those side effects resolve when you hold the antibody and let the brain heal up. And it may be that if you have that kind of response, you know that it's actively working, but it's a safety factor. So to minimize the danger of doing that kind of thing, you have to monitor with MRIs. So if you see it on the MRI, you stop the treatment until it clears up, and then you can reintroduce it and start it again, and people can tolerate it even better.
I'm not aware of it, Brian.
No, there's no connection I'm aware of.
There's some discussion that a number of neurological diseases might be affected by things that people are exposed to earlier in life, and they produce what's called epigenetic changes. So the biochemistry that's important in regulating which genes get expressed, that can be impacted by things like exposure to lead or exposure to other toxins. And so there's some research that has been done in the past, continues to be done, both related to Alzheimer's disease, Parkinson's disease, other neurological diseases, that trying to discern if there may be some common feature, at least as far as the sensitivity to things that are happening early in life that might affect your epigenome, but the pathology later in life is quite different. Brian's map, yes.
I think it relates to the demographics of aging for particular states. So there are states that are looking at, originally had a lot of young people, but now they have increasing percentages of older people. Whereas Rhode Island historically has been like anywhere from the third to the sixth highest population of people over 85, I think. At one time it was like the highest. So, and Rhode Island doesn't change their demographics much, so the increases are not as high as they are in other states where a lot of people now are staying in place and aging.
But it's mostly just population aging,
As far as I know, but that's a good question. Maybe there's more to it. But in terms of projecting, it would be based on age. So for ages, we know the prevalence of an incidence of Alzheimer's. So they take the population, the age, the numbers, and that generates the projections.
Rhode Islanders are interesting, actually. People that study the demographics of the state have discovered that Rhode Islanders tend to retire, move somewhere else if they're going to move somewhere else, and then when they're not doing so well, they come back.
Yeah.
So we lose them for a period of time, and then we get them back when they're not as healthy, unfortunately. That's right. Well, once you get that tax advantage, you don't want to give it up, you know.
The snowbirds.
That's right. Yeah. I have an interesting question to ask you. How many people think that the incidence, your chance, your overall risk of getting Alzheimer's disease is increasing as a society? It's increasing. There's actually evidence that it's false. Yes. Why? Right. So, well, that's the thing. So we have done things to address our cardiovascular health. We've done things to reduce the toxins like lead in the environment. And there is good evidence that in developed countries, including the United States, the first evidence for this came from Europe, actually, that the age-adjusted incidence is decreasing. Now, the prevalence is increasing because our populations are continuing to get older. But there's already good evidence that by paying attention to cardiovascular health, by taking your antihypertensives and your statins and taking care of diabetes and such, that we are actually already impacting our risk in a good way. What is unfortunate is that that doesn't hold well for underdeveloped countries. It doesn't hold at all for underdeveloped countries. And it doesn't hold well for disadvantaged populations within our country. So when you look at populations that haven't been as successful at addressing things like diabetes, obesity, et cetera, unfortunately, their age-adjusted risk isn't decreasing.
I think that's an important point. The Framingham study did show, decade by decade, the incidence going down. But what we're afraid of now is, right now, there's an epidemic developing of obesity and diabetes. And the concern now among people in public health is we're going to lose some of those benefits we gained over the years if people keep overeating and becoming sedentary and don't exercise.
Question over there? Yeah. Sure. So the gene can be identified in a number of different ways. There are now actually techniques that are available in the state of Rhode Island where you can get tested and learn almost right away. We all carry 2 copies of this gene, one that we inherit from our mother and one that we inherit from our father. And there are 3 varieties of the gene. It's apolipoprotein E is the gene that encodes for a protein that's important in carrying cholesterol and other lipids through the bloodstream, and is probably important in some way in stabilizing the membranes around cells. And so we have the ApoE2, the ApoE3, and the ApoE4 gene that we can carry. You can inherit a 2 and a 3 from your parents. You can inherit a 2 and a 4, 2 2s, 2 3s, 2 4s. It turns out that the ApoE2 variant seems to be somewhat protective. And if you have 2 copies of that, you seem to have a decreased risk of Alzheimer's disease. The ApoE3 is by far the most common. If you have 1 copy of the ApoE4, it increases your risk about 2 to 3 times. And if you have 2 copies, if you've inherited a 4 from each parent, it increases your risk. Now, it doesn't guarantee, but increases your risk between 7 and 10 times. And you can learn more about getting tested from the people in the back of the room. We all have one type. We all have two ApoE genes, and you can find out whether you've got the one you don't want to have, the ApoE4, by being tested. Some trials, many trials, will test. Some trials allow the tester to inform the participant whether or not what their result is, and some don't. So there's some variability in that, and I don't know. I know 23andMe went through a thing where first they would and then they wouldn't, and I'm not sure what the current status of that is.
In terms of our progression with research and arriving at, if not a cure, at least greater longevity. For instance, AIDS back in around 1980 was out of control, and we as a country, I guess throughout the world, threw resources at the problem, and with time, it diminished, longevity increased, and where it's no longer an epidemic. But it feels like we're still at an epidemic stage with Alzheimer's. Where do you feel we are with the research?
Yeah, I think that's a good point. A lot of money was thrown into AIDS research, more than Alzheimer research even, and it worked. But now, like I showed in the graph out in the beginning, we're increasing our investment in Alzheimer's research, so the expectation is that we're going to get results by doing that. You know, how much does it take, I guess, is the question. So the limits are the amount of money it takes to support the researchers in the labs, but as I mentioned, also the people in the community should volunteer to participate in the research studies is the other big limiting factor. So that's why we've been campaigning the past year to get people to volunteer to be involved in research. So that's just as important as getting dollars in. Yep.
So I'm kind of wondering how the different groups work together. I've done some studies at Butler. Are you doing the same studies here or different studies?
Yeah,
How aware should we know about that?
the big studies are multi-center studies, so to get thousands of people, those are cooperative. So you have multiple centers all over the country. It's not Rhode Island Hospital study or Butler study, and a lot of them we all do. So you can do the same study at Rhode Island or Butler or mood and memory disorders. So you do have choices in the state of where to go, but we work together insofar as we're all following the same protocol, we work by the same rules, we collect all of our data, all the data is shared centrally, and by having all of those centers, you can carry out these huge studies, which take a lot of time and energy, so it really is a cooperative venture on actually even an international level.
There was a video maybe a year and a half ago on public Nova, and I was amazed to see, I just happened to see it, and it opens up with Dr. Salloway going in his office to meet a mother and son, and then they went to doctors in Brazil and all over the world. It's unbelievable. If you go to Nova and say Alzheimer's, they have another computer
Mhm.
And they had a family there in Brazil, I think, 6 of them.
Oh, in South America, there's a family of people where they have autosomal dominant Alzheimer's, where half the people in every generation get it. But that's different than the ApoE factor. So
Yes.
that particular study is being led by people at Banner in Arizona. It's gotten a lot of press because it's like this really interesting population, sort of, it's like a town where half the people have Alzheimer's disease. It's very unique. So that kind of autosomal dominant inheritance pattern, though, only accounts for maybe 1% of the cases of Alzheimer's. So although it makes for great news stories, we don't know how much that really applies to what we call sporadic or the common variety of Alzheimer's that comes at a somewhat later age in life. But it is one route to get it is through genetic dominance in a small number of cases.
Woman in the back, you've been trying hard. Sorry.
I have 2 questions not related. The first one is the ethnic variability. Is it Alzheimer's more prevalent in one ethnic population than another? The second question is, as we know, Alzheimer's is a very labor-intensive and expensive illness to care for. In the state of Rhode Island right now, we have somewhat of a crisis in caregivers. We do not have enough paraprofessional caregivers. And I know that's not your department, but do you have any information on how we're moving forward to meet the needs of the individuals with the education and staffing of the facilities, and whether inpatient, outpatient, or supportive families in Rhode Island?
That's a complicated question.
No,
I'm in the middle of that.
I can say a couple things. So there are organizations in the state that you may be aware of, like the Diocese of Providence is very prominent in caregiver support and education, respite care for people that are caregivers and need a break. The Alzheimer's Association also is very active in that area. The state plan has a subcommittee on caregivers, and one of our Ryan Institute folks, Chris Getter in the back, is on that subcommittee and can tell you a little bit about what they're up to right now. It's a big issue. It's very hard. It's the most costly aspect of the disease relates to caregiver expense, time away from work. A huge percentage of the people who are caregivers end up having to leave work or dramatically modify their work schedule to be able to care for someone. I'll let Brian take it from there.
Yeah, so there is a shortage of home health care workers. And the main reason, well, one of them, we need to train more people in Rhode Island, but also we need to pay them more because they can go work at Walmart in Seekonk and make more money than they can being a home health care worker. So they need to pay these people more for the work they do and needs to be competitive with neighboring states, with Massachusetts and Connecticut. But as Bill mentioned, we have the state plan going on now, and that's a good place for people who are advocates to channel their suggestions and their questions, either to the subcommittee or directly to the Lieutenant Governor's office if you have concerns or ideas on how to deal with that.
The compensation to facilities is going down, which is why they can't pay their workers more. The state and federal funds to care for the patients keeps going down. So the facilities are doing more and more with less and less. But that's just a reality. What about the ethnic question?
Oh, yeah. There are changes in ethnic prevalence. For instance, in Asians and people in China, there's a much higher prevalence of vascular dementia rather than Alzheimer's disease. In England, in that area, there's a higher prevalence of Lewy body dementia, which is another form of dementia. We don't understand exactly why those differences exist, But if you come into America and you eat the atherogenic diet that we all eat, those differences seem to disappear. So it may be related to things like diet and lifestyle differences, more than to the actual genetic makeup of the ethnic person.
Brian's a lot older than me, so I'll let I don't know, I can't go back that
Thanks,
far.
Bill. Yeah, in the 60s and 70s, they were calling it hardening of the arteries. And, you know, Alzheimer's original case was in her 50s. And so Alzheimer's disease was regarded as a disease of the what they called the pre-senile period, which were people, you know, under age 60. And then in the 1970s, it was recognized that the old people dying with dementia had their brains looked the same as the younger people with Alzheimer's disease. So that's where things changed, was in the 1970s, where we started calling it all Alzheimer's disease, but with a different onset, early and late onset. So that's led to a lot more cases being called Alzheimer's disease rather than senility or hardening of the arteries. So that was just a matter of classification. And the other thing that's led to an increased frequency of diagnosis is, as I mentioned, with treatment, people come in to the doctor's office now and they get evaluated and they get diagnosed. And you have specialty clinics now who will diagnose Alzheimer's disease rather than saying you have dementia, that non-specific generic term. As it turns out, the American Psychiatric Association ditched the term dementia a couple of years ago. So we call it major and minor cognitive disorder.
Just to keep things interesting. Yes?
So relative to that, I had a friend probably 20 years ago whose father was diagnosed in the 50s, and the physician at that time said, when you're diagnosed at that young age, the disease has a very long and more torturous progression, whereas in the 70s, the mortality is a little bit closer. Was that something that you heard or seen, or was that just something a physician threw out into?
Well, the younger people do live longer because they don't have so much heart disease and other problems.
They
So,
made it to that age before they've been diagnosed.
so they can progress more from the brain disease because they don't have something else taking them out of the picture beforehand. That's why if we can just prolong the onset to later years, we'll have fewer people with the disease because they'll succumb from other things that you might rather pass away from rather than Alzheimer's disease.
The woman with the striped shirt, you've been trying hard too.
Yeah, and a big change came when Reagan was diagnosed with Alzheimer's disease. I don't know if you remember that, but all of a sudden they realized even the President of the United States can have it. And with that, you know, people started coming out and saying, well, I can talk about this, so there is this closet issue. So that's one challenge. And even primary care physicians may not be comfortable with making a diagnosis. They're busy with everything else, and they don't want to take the time to deal with it, and so people may not get recognized early enough because of that situation. So we need to raise awareness and interest among all the physicians out in the community. I think that will make a difference.
Another thing that is important that I've learned is that there are many ethnic populations that tend to treat the fact that a family member may have signs of dementia differently. So in some cultures, it's something that someone might be more comfortable bringing to the attention of other people, including the doctor. And there are other cultures where there's a strong influence to not admit that someone might be having trouble. And so there's one of the things that becomes apparent when you talk about media campaigns is how do you reach these populations that may be most resistant to opening up about the disease. A lot of hands. Yes, ma'am. This is one for you, Brian. So this is a family member that was diagnosed by their primary care physician. Now you're having trouble where to go because the family member, him or herself, doesn't want to.
The patient doesn't want to cooperate. Yeah, so that's a tough situation. That's one of the advantages of early diagnosis. If you get people early, you're more successful getting a person to be aware of their deficit and to cooperate. But if they've gotten to the point where they now have dementia and they don't have awareness that they have a problem, it becomes very difficult for a physician to help. You can't do anything in that situation. So you have to rely on family members to get through to the person. Or to identify a physician or healthcare worker that the person trusts and will believe in. And that in some people, they don't get care, and they become very resistive, and it may be personality factors too. There are people who never trusted the health profession and never wanted medications, and you can't change that personality. And so those people may end up leaving and go to crisis mode until there's a crisis. And they end up in the hospital with a confusional state from an infection, and then the healthcare system kicks in and steps in. But it's not the way to do things if you can avoid it. Sometimes you can't do anything about it, and it's not the fault of the family members, but it tends to generate some guilt and stress when you can't do anything to help the person.
I would
That's
reach
why we
out
have
to
support groups.
Yeah, reach out to the Alzheimer's Association
Yeah.
and learn more about the support groups because they have many, and you may find that you're not alone. You will find that.
Yeah.
It's the woman behind you. Yeah.
Yeah, that's the most common question that always comes up. And I tell people in the office, you just don't use the term dementia. And then you're not going to be confused. Dementia was a term developed in the 1700s. I don't know if we have any Latin scholars, but it comes from de, de means out of, and mens, which is the Latin word for mind. So in the 1700s, when they had people who were out of their mind, they called them demens. And in French, it was called demens, and then in England, they changed it to dementia. That's the origin of the term. But back then, they had no way of making a diagnosis. So people who had demens or dementia were people who had brain tumors, schizophrenia, strokes, vitamin deficiencies, brain infections. It could have been anything. They call it all demens or dementia. And so that sort of generic term carried through into the 1970s, unfortunately, and it doesn't help you at all. It just says you got a problem. And so if you don't use, and that's why the American Psychiatric Association got rid of the term. And if you just recognize you have a cognitive disorder, you have a problem with your memory, then people realize that's not the diagnosis, but you've got to figure out what's causing it. And the most common cause of a major cognitive disorder or demens or dementia is Alzheimer's. But there are 70 other possible causes. So calling it dementia doesn't help. I think it's a roadblock, actually, to understanding what's wrong with somebody. So just forget it. Dementia, a word to be forgotten. There's actually an article called that. Came out in Archives of Neurology 10 years ago.
Yes, gentleman with the glasses.
I saw in your presentation that the Mediterranean diet is recommended to reduce the risk for the disease. Can you explain why that specific diet kind of recommended?
So there is, at the time that paper was published, there was uncertain evidence for the Mediterranean-style diet. The evidence since then has improved, but it's still not strong. So there's moderate evidence that a Mediterranean-style diet, a MIND diet, which is a variant, a DASH diet, another variant. There are now a number of different styles of diets that focus on green vegetables, multicolored vegetables. There's argument as to whether or not fish is important or not. Nuts are considered important. There seems to be a connection between diets that are low in red meat, especially, and preserving cognitive function. It's not clear why. It's probably related to the fact that many of the elements of these diets are also anti-inflammatory and have cardiovascular benefits. It's just been difficult. It's incredibly challenging to do that type of study, especially because of the length of time required to initiate a scientific intervention where you can study, okay, you're going to eat it, you're not. It's usually done on a population basis. And so you have people that adhere to that diet in a variety of different ways. Some consume more green leafy vegetables, some consume more nuts. And it's really hard to find what's the most important thing. The other thing that's hard in these studies is that people lie. Now, they do that with the exercise trials too. Yeah. It's hilarious sometimes to actually compare what someone self-reports and what you objectively observe in a trial. People will, if it depends on the gender of the person asking the question, all kinds of things impact that. They get notoriously unreliable. We're all really bad when we self-report. Yes? There are a number of different options, and Brian, you can address it. You have people in the back that can also address it. The one thing I'll say before handing it to Brian is that the trials are now tending to look for people that have less advanced Alzheimer's disease because it's hoped that they have the greatest opportunity to impact the progression.
I didn't
So
actually hear
the question was that you had mentioned clinical trials and that there are a number of different ones, and she was asking, like, at what stage does one qualify? Mild cognitive impairment, more advanced, earlier?
Yeah, so what we do at our center is we have what we call a portfolio of research trials, and we try to have something that will fit just about everybody. So we have studies for prevention, and we have the Alzheimer's Prevention Registry for people who have no symptoms. We have a number of trials for mild cognitive impairment, but we also make sure we have some trials for people who have established Alzheimer's disease at the mild stage, but also even at the moderate stage. And it's hard to find now trials for moderate stage disease because the sponsors are just not moving in that direction. But we do have one, for instance, even at moderate stage disease. We don't have anything going for severe stage disease, though, unfortunately.
In any of the trials that you were just mentioning, does a participant have any way of finding out what the two variables of that OPE 2, 3, or 4, what their genetics look like? Is that ever part of it, or is that something a person goes to a doctor to have that information?
So Bill talked about the ApoE. You can check it yourself as program 23andMe. It used to be illegal, but now the FDA opened it up so you can test yourself for a couple hundred, actually I think it's less than 200. But we don't recommend that because you should get some genetic counseling with the information. But it's a free world now, you can self-test. In the registry, we don't give people the information. And most of the clinical trials, people don't know unless you have to. So if a criteria is you have to have an ApoE4, then you have to tell the person in that situation. But most of the trials, we check it and we use it just so we can stratify how we analyze the data. We don't share that information with the patient. So you say, why don't you tell everybody? We did a survey once of the people in our registry, and we asked them, would you like to know your ApoE status? And would you like to know if we did an amyloid PET scan, whether you had amyloid plaques in your brain? And 80% of the people said, yeah, I'd like to know that information. So people do want to know, even though they don't have dementia. But then we asked them some other questions. We said, wow, why do you want to know? And the most common reason was so they could make a decision whether to go into a clinical trial. So that's a good idea. But about 11 or 12% of people said, well, I'd like to know because if I have the risk factor gene, I can plan my suicide. And I don't know if you saw the movie I'm Still Alice, but it's that whole idea that, if you don't want to get a disease, you can plan how to have yourself eliminated. And is that a good thing? Is that a good outcome? We don't think so. And how do you figure out who's going to use the information for not such good reasons? And the American Genetic Society recommends against normal people checking their ApoE because of that issue, but also because there's no treatment. If you got the ApoE4, you can live to the age of 95 and never get dementia. And yet you could go live 40 years of your life worrying that you've got Alzheimer's for no good reason. So that's not a good outcome either, to get people worried and nothing to offer. What we hope to do in the near future, though, is if we can come up with a treatment that will reduce your risk or prevent you from getting it, then we'll tell people, yeah, check your ApoE like we check people's cholesterols, because then you can give a statin to lower your risk. But we're not there yet with Alzheimer's and ApoE. Hopefully that makes sense. The PET scan actually tells you not that you're at risk, it tells you you're developing amyloid plaques in the brain, and that's a component of Alzheimer's disease. It tells you that with about an 80 to 90% certainty, not 100%. But about 30% of people over age 65 will have a positive amyloid scan. It's like atherosclerosis. Most of us over age 65 will have some of that in our vessels. So does that really help you to know that? It would help if you had a treatment to say, okay, get rid of that stuff.
So even if you knew at 40 years old?
Yeah, so our ability to diagnose and recognize these biological markers is outstripping our ability to offer a risk-modifying treatment. That's the challenge right now. We're trying to catch up and come up with those treatments, but that's, like I said, we need to get people into the trials to find the treatment to offer to offset that risk if you do have plaques or you got an ApoE4.
I'm hoping that as a result of what you've heard tonight, you might feel the need, or the desire, the stimulus to go to the back and perhaps introduce yourselves, learn a little bit more about the things that are happening in the state, and to give you a chance to do that and not keep the people that are manning the tables here too late. Maybe we should stop and give people a chance to do that. I'll still be here. Dr. Ott, I'm sure, will stick around for a little
All right.
bit. Do you have
Thank you.
questions? Thank you.